Welcome. I'd like to welcome everyone to our webinar today, Incorporating Point-of-Care Diagnostic Tests into Ambulatory Urgent Care Workflow, Choosing the Right Test for Your Clinic. This activity is sponsored by an unrestricted educational grant from Roche Diagnostics. My name is Christopher Chow. I'm the Medical Director of the Urgent Care at WakeMed Health and Hospital in Raleigh, North Carolina. I'm active with the Urgent Care Association, serving on committees and speaking on a variety of clinical topics. Disclosures. I'm a speaker advisor for AstraZeneca and Abbott, and I work as an advisor for Pfizer, bioMérieux, and Roche. I'm also on the editorial board of EB Medicine. The opinions expressed in this presentation are of my own and do not necessarily reflect the sponsors. Our learning objectives today are to differentiate diagnostic testing modalities and regulatory categories, to align diagnostic testing platform selection with clinical use in urgent care clinics, 3, evaluate operational trade-offs of point-of-care testing, 4, incorporate diagnostic stewardship principles into platform selection, and 5, align implementation challenges and workflow integration. Some background before we begin. Over the past decade, point-of-care diagnostic test options have expanded rapidly. While traditional antigen-based tests remain a cornerstone of urgent care diagnostics due to their speed, simplicity, and affordability, newer technologies, including CLIA-waived molecular platforms, multiplex assays, and host response biomarker tests have significantly expanded the diagnostic toolkits available to clinicians. These advances provide faster and more actionable clinical information at the point of care, creating new opportunities to improve patient care while introducing important operational, clinical, and financial considerations for urgent care leaders. What would the perfect diagnostic test look like? In the ideal world, the test will have 100% sensitivity, which never misses disease, 100% specificity, which never misclassifies a healthy patient, rapid result at the point of care, instantaneously if possible, easy to perform with minimal training, non-invasive specimen collection, affordable to purchase and operate, widely available, reimbursed, and fit seamlessly into clinical workflow. Unfortunately, there's just no easy button. Every diagnostic test involves trade-offs between accuracy, speed, cost, workflow impact, regulatory requirements, and clinical utility. The right test, not the perfect test. The best test depends on the clinical question and the clinical situation. I once had a photographer tell me, the best lens you have is the one that you have on your camera. The best test you have in your clinic is the one that you have. You got to know how to utilize it. But higher accuracy is not always better. And operators should evaluate tests holistically, considering clinical performance, reimbursement, staffing, training, quality control, and turnaround time. Your goal as an operator and decision maker is not finding the perfect test. It's finding the right test for your patients, clinicians, and clinical workflow. We talk a lot about antigen versus molecular testing, and I think it's important to review the nuances between antigen and molecular testing. Antigen tests detect protein produced by a pathogen. It's relatively inexpensive, fast results, and portable. The caveats is it's not as accurate as molecular testing, with a higher risk of false negatives compared to molecular. There are currently home tests or antigen tests, although there are a few molecular tests that are now available as a home test. Tests may be negative in early disease. Compare this to molecular tests, which detect nucleic acid, that's RNA or DNA. It is the current gold standard for many common infections seen in urgent care. It does have the highest sensitivity, and it can be point of care or reference. They are relatively expensive compared to antigen tests and require a device to perform and read the test. But note that the presence of nucleic acid doesn't imply active infection. As we found out with COVID, sometimes molecular material, DNA or RNA, can be detected for weeks or months after infection has resolved. There's also the human factor in diagnostic testing. Analytic performance is only one component of diagnostic accuracy. Most testing errors occur in the pre-analytic phase, which is collection, handling, storage, and transport. Following manufacturer instructions is essential to ensure reliable results. Operator training and competency directly impact test quality, and every clinic should have a strong quality assurance process to reduce avoidable testing errors and improve patient care. The best platform, the best test, cannot overcome poor collection, workflow failures, or inadequate quality control. I'd like to touch base on CLIA-waived versus CLIA-moderate. The advantages of CLIA-waived testing is its easier implementation, less regulatory oversight, faster staff onboarding, lower compliance burden, and it's well suited for urgent care. Basically, your clinic has a CLIA-waived certificate, and if the test is CLIA-waived, you can perform them without additional oversight. The advantages of CLIA-moderate are broader test menu, higher throughput options, there's more advanced diagnostics that are available with greater flexibility for specialized testing. But the downside of moderate complexity is you need proficiency, you need competency, you need additional documentation, quality management requirements, inspection readiness, and staff training time. The nice thing about advances in diagnostic technology is that they've expanded the available CLIA-waived testing, allowing urgent cares to offer sophisticated molecular and infectious disease diagnosis without having to go to moderate complexity. So the growth of CLIA-waived molecular diagnostics does shift the conversation from can we offer advanced testing to what level of operational and regulatory complexity are we willing to support? Before we adapt any test, does it change clinical management? Is the test clinically accurate? Does it fit workflow? Is reimbursement adequate? And does volume justify implementation? Some common pitfalls that operators and decision makers make. We choose a test based on accuracy alone. The salespeople love to come in and say, we have the most accurate test. But does that test fit your workflow? Which leads into number 2, ignoring workflow impact and overestimating volume. You also have to be mindful about ignoring staffing requirements and not having QC. And finally, implementing a test without ensuring your clinicians can properly interpret the test. This is a nice summary developed by one of our panelists, Jessica Higginbotham, which basically allows you to make a matrix of what the domains to evaluate when you're considering implementing a test. Obviously, the clinicians will focus on the clinical, and the operations will focus on the operations, and the financial will focus on financial. But all three are important because they all come together to form sustainable patient care. The best diagnostic test is not necessarily the most accurate test. It is the test that delivers clinically meaningful, operational feasible, and financially sustainable patient care. Accuracy gets a test considered. Workflow and economics determines whether it succeeds. At this point, I'd like to introduce our 3 panelists. Payman Arabzadeh, Dr. Arabzadeh, MD, MBA, is the CEO and Medical Director and Chief Promise Officer at Davum Urgent Care in Magnolia, Texas. Davum Urgent Care is a 3 urgent care system that encompasses both a suburban and rural environment. Lisa Bishop, DMP, MHA, FCUCM, brings 25 years of clinical and leadership experience to her role as Vice President of Training and Clinical Development at Premier Health Consultants. She is a seasoned healthcare consultant with a passion for driving transformative change in urgent care. And finally, we have Jessica Higginbotham, PharmD, BCGP, and BCCP, who serves as the Vice President of Clinical Services at American Family Care. American Family Care encompasses over 400 urgent care clinics across the United States. And Jessica leads strategic goals across radiology, laboratory, pharmacy, clinical research, and quality. Dr. Arabzadeh, Lisa, and Jessica have the following disclosures. So let's welcome our panelists, Jessica, Payman, and Lisa. Thank you for joining us today. I'm going to start off with a loaded question. Payman, what is the biggest mistake urgent care operators make when selecting a new point of care test?
Thank you, Dr. Cha, for having me on this distinguished panel. And this is a hot topic in our industry, and I'll be more than happy to contribute. The simplest answer would be the clinical staff and the management or the owners or the operators, they do not consult with each other as what type of test. If somebody sold on the test on the management side, but without the contribution of their clinical nursing staff and the workflow, that really is going to come into a clash and will not have a long-lasting positive process for the center, for the manufacturer, for the community. So that would, to me, that's the easiest and the first thing that could create a, we have this test where we're not using it. Other things involved that could be go into the same concept, the cost, the accuracy, the reimbursement, which we're going to talk and go further into as we get into these questions. But the main thing is you need to have everyone's buy-in or feedback before you implement a test into your centers.
Yeah, Payman, I think that's really an excellent point. We focus so much on the test itself, but a lot of times we never focus on the workflow and the process and how easy it is to obtain a sample or whether or not the test needs refrigeration or not. Lisa, I think you had some lessons that you learned in your healthcare systems from COVID.
We did. So, we always have to think about the workflow impact. When you're looking at a test that is going to add 15 or 20 minutes to your door-to-door time, operationally, that's how it's affected. But also, when you have a test that is the gold standard of testing, yet you find out months into the equation that you're maybe paying more than you're getting reimbursed in some of your states for this test. It creates a problem, not only operationally, but financially for your organization. So I think both of those factors need to be factored in when thinking about how we're going to choose this, not only clinically, but we also need to look at it operationally. Yes, we would love to have something that is at high specificity and sensitivity, and the collection is easy and it's the gold standard, but we also have to think about the overall impact of the organization nationwide, especially for a large organization such as Jessica's, who has over 400 clinics. That one reimbursement snag, as I'll say, could be millions. So I think we have to look at both factors.
Jessica, do you have any final thoughts on this question?
No, I think they both spoke to it beautifully. I think really just highlighting the communication between, operations, clinical, and financial is imperative.
Thank you, guys. Let's moving on to question number 2. What factors carried the most weight in your decision-making process? Clinical value, reimbursement, workflow, or patient demand? Jessica, do you want to lead us off with this question?
Yeah, that'd be great. So I don't think one carries more than the other. Honestly, I think it has to be a balance. It has to be, you need to be thinking about, first of all, is it even appropriate for your CLIA status? Number one, right? You need to be thinking about sensitivity, specificity, comparison to the standard of care. The technology type, the ease of use. Are we asking for nasopharyngeal or is it a more simplistic swab, right? So like all of these things need to be considered. You need to look at your platform requirements. How much space does the equipment take up? How many tests can you run on that piece of equipment at the same time? Like all of these things need to be weighed and considered during that evaluation.
Jessica, how important is interfacing with your EMR in lab selection?
I think it depends on the number of results on the panel. So if we're talking about a test that is binary, maybe interfacing is not the most important thing. If you're looking at a multiplex panel, I would encourage you to consider an interface for that. That's a lot of steps for your staff, and it's a lot of opportunity for human error. So if you have got a multiplex panel, I would encourage an interface.
And for our listeners who aren't familiar with the concept of interfacing, it just simply means that the equipment or the lab communicates directly to your EMR without having manual entry. Payman, do you have any thoughts from a 3 urgent care system?
I think at the end of the question, you should have all of above to include everything in there. But I would say the manufacturer that you select, you want to make sure they're going to be in business down the line. We see a lot of companies, they come and go. And then when you need them the most, for whatever reason. So all of those are important. But one thing I would consider that make sure it's not a fly-by-night type of a lab and a company that you're going to have to go back and change. But Jessica said it beautifully. I don't think I can add anything else to what she did mention.
Great, thank you. Moving on to question 3. Lisa, have you ever implemented a test that looked promising but ultimately failed to deliver value?
Yes, we have. Unfortunately, like many organizations, we implemented tests that appeared promising on paper, but then ultimately did not deliver what we expected operationally or clinically, and it did not add clinical value. And so when selecting tests, we always have to think about what is the clinical value? What is the value to the patient? Is this going to change the outcome? Is the results going to change our plan of care? So, one test that I remember that failed ultimately, we had vetted the product, we had researched, it met our criteria for specificity and sensitivity. And so we implemented it across the nation, and the test did not prove to be as reliable as we had anticipated. We were getting a lot of false negatives, and of course that led to patient dissatisfaction, which led to our staff dissatisfaction with the test and lack of confidence in it. And we've also, have to think about the challenge of if it didn't meaningfully change our clinical decision making or fit into that urgent care workflow, was it really something that we should have utilized? And we have to think also about, it always comes back to the reimbursement. I hate to harp on that. As a clinician, I want it to be all about the clinical value. And I know, Jessica and Payman can relate to that, but operationally, we have to think about the other side of that coin. If you have a test that is promising or great, but yet it does not add monetary value or actually detracts and takes away your return of investment or your profit margin, then it's not something that needs to be utilized, unfortunately.
Yeah, I think that's an excellent point. Payman, have you had a test that looked promising but ultimately failed to deliver value?
I cannot think of a specific test, but what I will do is we do a lot of due diligence up front. And by selecting the test that we feel like is going to work with our workflow, we go with that. But if the test that you're getting and it's not working, I don't think you should spend a lot of time trying to fix the issues. If it's not working with your workflow, what have you, I don't think you should really exhaust a lot of labor and staffing and cost into it. And a lot of companies, they do maybe allow a testing that you can try and equipment or try a test to see if that would even work in your system. So I would take advantage of it, or at least ask them, can we have a trial period, or give me a few hundred tests, let me see if it works, how I get reimbursed, and if it's a good fit, then we move forward. So at the end of the day, you have to be able to kind of a bargain with your vendor, with your manufacturer, what have you, to make sure you find the test that you're going to stick with, because all of those cost all kinds of effect it has to your bottom line and your staffing.
Great, thank you. Another loaded question, since we're talking about antigen versus molecular, what barriers do you experience when considering molecular testing? Jessica, do you want to answer that one?
Sure, I'll kick us off. So in terms of barriers associated with molecular testing platforms, I know that probably the one that sticks out or is the first thing on people's radar is cost. These tests are more expensive. They just are. And so you need to make sure that you build a model, or you model out something that makes sure that it makes sense before proceeding. Another piece of that is, in contrast to an antigen test, which is often a lateral flow, you have to consider how many tests you can run on that module at one time. So that's, if you're a high volume clinic and now you can only run one test on the module at a time, and each one takes 15 to 20 minutes, you're in a bit of a pickle, because now you've just really affected your turnaround time. So those are the two things that come top of mind.
Lisa?
Yeah, I agree with Jessica. Well put. You have to think about the biggest barriers. And again, to her point, usually it's not the technology, because molecular platforms are excellent in their performance, but the challenge is going to be to determine whether that does create enough clinical value to justify the investment, also enough operational value. You also have to think about so many operators that have global plans, and those global plans and the cost of those tests are going to be coming out of every visit that's coming through there. So you have to weigh all of that in, the cost, the return on investment, your workflow integration. So all of those things can be barriers, I think.
Payman, do you have anything to add?
Actually, I wanted to mention, if you hear something from another urgent care, or you go to convention and you hear from people, you really need to consider what type of settings they are. Are they a health system? What type of contracts they are? Because somebody says that they're getting paid for this test X, Y, and Z, and then all of a sudden you get excited, and then you go invest in the equipment and buy, train, everything. And then you realize, oh my God, my contracts, my whatever I have, they don't reimburse me. Then by the time you want to find out, you're a few months and a few $100,000 into debt, that it's going to be a disaster. So really do your due diligence up front with your billing team, get the code, run few tests, see if you get reimbursed. And at the end, it might change tomorrow. So you really have to be careful whenever you implement a expensive proposition when it comes manpower or financials.
So we talked about barriers, but there are also some disease states where molecular testing really does outperform antigen testing. I'll give an example with strep testing in children. If you have an antigen test and it's negative, you need to have a confirmation test. That's in the manufacturer's recommendation, an AAP recommendation. But if you have a molecular test, then it's considered final. No confirmation test is needed. So from a clinical side, is there situations where you may see a benefit from implementing a molecular test in your clinics based on your patient population? Jessica, at AFC, do you guys take this into consideration?
Yeah, that's a great call out. And honestly, a beautiful example. Like, I can't think of a better, well, maybe STI testing is another wonderful example of really having the result that you want right now. I think there's immense value in this. I mean, not just from a clinical perspective because of the efficacy and accuracy associated with these tests, but also from a patient satisfaction standpoint, right? Like, think about it from the parent standpoint, typically, in this demographic we're talking about, like the value of having the results of that test at point of care, that's huge. And it's a workload situation, right? Like, that's one less phone call that your team has to make when that send out comes back. So that's another value add.
Thank you, Jessica. So how do you guys feel about multiplex testing? Once upon a time, it was one test, one pathogen. Now it's not uncommon to see 3 or 4 plex testing. The common combination is influenza A, B, COVID, plus or minus RSV. But the technology has improved that we are now seeing larger multiplex testing options. What are some of the pros and cons of multiplex testing? Jessica?
Can you saw I'm over here bubbling? I love multiplex testing. I like it because maybe my background as a pharmacist makes those conversations with patients a little bit easier. When people come into urgent care, there's an expectation that I'm going to get tested. I'll know exactly what I have when I leave here today, and then I'm going to have the treatment necessary. Most often, maybe a particular antibiotic or cough medicine or something of that nature when I leave here. And so, having a multiplex test in your center really helps with those conversations. It helps people to say, look, you have rhinovirus. Rhinovirus is not treated with an antibiotic. So as a result, I'm not going to be writing you an antibiotic today. What I am going to be doing is giving you some medication that's going to help with these symptoms you're coming in here with today. So let's see if we can get you feeling better. I mean, I think that having the results of that in your hand really helps to facilitate those conversations.
Lisa, do you want to have anything else to add?
I think she said it beautifully and very, very positively. I can tell it excites Jessica, and it should, because it's always not just the workflow, but you're getting multiple results from one test, so you don't have to wait. And you got the rapid identification of those pathogens, so it does support your antibiotic stewardship efforts. One thing that I will say is a disadvantage is sometimes, they're going to be slightly higher costs. So again, you have to think about reimbursement. I feel like I'm harping on reimbursement. You have to think about also your staff and their training and their competencies as far as collection. And also you have to think about your reimbursement from your payers. Not all payers will take that RSV test and reimburse you for an adult patient, even if it's part of an RSV COVID influenza test. So you have to think about that as well. Again, I think one thing that we do see that is positive, to Jessica's point, when you're looking at like STI testing, multiple testing for that, I think it's great in that you've already identified the pathogen, so you really combat your antibiotic stewardship mission, your goal. You're not saying, well, you've been exposed, you have some symptoms, let's go ahead and treat, we'll wait. You don't have to do that. You don't have to have them on an antibiotic for 3 days only to call them back and say it wasn't what we, anticipated. So I think that's a big thing as well.
So there's something I want to circle back. You said something that we haven't really talked a lot about, Lisa, and that was knowing what to do with the results. So I think that's something you also need to take into consideration with your teams is like, okay, great. You just ran a multiplex panel. You should probably provide your team with the resources necessary to know what to do with the results of all these different things, right? And so some of the things that are going to show up positive on that panel don't warrant antibiotics or antivirals, or, there's other considerations. How long have we been symptomatic, right? I mean, we're talking about flu. There's just a lot of other educational pieces that are going to be indicated here. But you can certainly it's certainly important to give your team the tools necessary to be successful in regards to that as well.
I agree 100%. And that's the difference between between the point of care and those that you get the larger multiplex respiratory panels. It just depends on your diagnostic ecosystem. What is your workflow? What are your protocols? And absolutely be sure that you educate not only your staff, but your clinicians, know when to treat uroplasma, know when not to. I think that's a great point, Jessica.
Yeah.
Chris, I don't think you've lived unless you try to poke a 2-year-old 3 times in the exam room, and all of a sudden they become a Hulk and nobody can keep them down. So for the parents and for the kids' sake, I think they come really handy. Just letting the parents know this test includes X, Y, and Z, so they don't say, oh, I don't want to be tested for this one. Then you're kind of stuck with it. But I feel like they have become more popular with the staff, parents, and all the patients, all alike.
Great. This is an excellent discussion, and you guys have brought up some absolutely great points about the pros and cons of multiplex testing. For STI testing, Jessica and Lisa both alluded to this already. How important is it to have the results at the time of service?
So yeah,
Lisa?
I'll take that. I really do think it's the ideal situation to have that actionable results at the time of the visit. The rapid turnaround is often more important. You have the patient satisfaction aspect of it, you have the antimicrobial aspect of it. And a lot of times, we'll see that those STI tests, because they may be a little bit more expensive, they're not utilized, especially for global plans. So for those larger operators or operators in states that their global plans do not cut out, testing for their part of their reimbursement, going to them and having those negotiations at the table with your payers saying, okay, guys, if we can allow a cutout for this STI test, you're not having to worry about them getting a prescription for an antibiotic. You're not having to worry about, all of the things, and it actually reduced your cost. And so I think those, they're ideal as far as the situation to have those actionable results, but it's also from a payer perspective, you should have those conversations as well, because that's a reality of, urgent care. Our profit margins are not as great as, say, a hospital system. So we have to think about those things.
Heyman?
I agree with Lisa. I don't think she could have, I can't say it any better. There's a clinical aspect, then there is a real life aspect of this, that the real life is sometimes people want to be discreet. They don't want the insurance company, they don't want the credit card company, they don't want anyone to find out about certain type of test for whatever stigma or things that comes with it. So just for that aspect, if it's just a few percentage of the patients that might benefit from it, having the testing done and the results available right away, you're probably providing a service to the patient as well. But it's one of those things you want to know right away, are you pregnant or not? You do 10 tests and to make sure it is what it is. So people want to know and they don't want to wait. The waiting process kind of plays on their mind a lot. So I feel like anyone can implement those tests, that they're reliable, and having the results at the time of the test, it will benefit them.
Jessica?
I agree. The only thing I can add possibly is that the alternative to not having the result is empiric therapy. So like in a lot of these situations, we're talking about like, yeah, we're going to have to, you can do a watch and wait, or there's lots of other options. With STIs, often that's not what we're talking about. We're talking about you get empiric therapy. And so when it comes to antibiotic stewardship, this is probably the biggest bang for the buck.
I think also just wanted to add that we underestimate the medical legal risk of a patient that's lost to follow-up. I mean, how often in urgent care do we have someone come in, we run STI testing, and we wait for the result, and then we try to call them, and the number's been disconnected. Okay, we call their emergency number, their number's been disconnected. I personally believe that point of care STI testing is absolutely important. And that's really where the transition from having options of having point of care STI testing have really made is a game changer in my opinion. Payman, do you have something to add? Okay, gotcha. So let's move on to question 7. Let's talk reimbursement. Okay, what challenges are all of you facing? I mean, you represent some diverse clinic types, and we've heard the reimbursement piece, but let's start off with Jessica. What reimbursement issues do you guys see at AFC?
Well, we're across several states, so it varies incredibly depending on what state we're talking about. I think, some of the challenges are associated with how the contracts are set up, right? So like we're talking about adding on a lot of different tests or bringing a lot of things in-house. That becomes challenging if you're on a global rate. So that's probably the largest challenge I see as we're talking about bringing more tests in-house and reimbursement.
Jessica, and for our listeners who may not be familiar with the concept of global rate, it's global rate or case rate reimbursement, which means that the insurance company pays you a flat fee for every visit, regardless of what you do or don't do. So unfortunately, as you've said, if we're running some of these tests that are pricier, we can actually be in the red for a visit.
That's right. So it
Yep.
becomes a little bit more challenging. And some might argue that having your contract set up in that way may potentially lead to degradation of care, which is the opposite of our goal. We really, we want to be functioning at the top of our license and doing everything we can to keep patients out of the emergency department.
Payman, as a small urgent care system, what challenges do you face?
But one of the things we decided from the very beginning when we opened our urgent care was to provide certain tests, such as we do in-house CBC, CMP, cardiac enzymes, D-dimer, that they put you in the moderate complexity. And the cost is you probably lose some money on those tests. But if you look at the medicine as a transactional process, you probably will never implement those tests. But we live and we work in this community and we provide a service that is needed. And that was our decision from the get-go, just like we start taking TRICARE or military type insurance care. We wanted to provide a service that the patients, they don't have to come in and then you transfer them to another center to get, or hospital. Then the cost to the patient is tremendous. And just by doing that, it's like you have your loss leader in the grocery store, if it's a milk or what have you. Patients will come back and they remember that you saved me a trip to the ER. And when we compare our, for example, transfer rate of patients to the ER versus the patients that we don't transfer because we were able to perform the CBCs, the CMPs, the cardiac enzymes, and do the things that we do in our centers, we see that a tremendous, I would say, less transfer. Where like transfer rate is like under 1% versus other centers or health systems that the transfer rate could be anywhere from 10 to 15%. Yes, we will lose maybe on that one patient, but coming back, the patients coming back, the families, it it's a different type of experience versus I know if I go there and I say I have chest pain, they're going to send me somewhere. As soon as I said I'm short of breath, they're going to send me somewhere. But, just like Jessica and Lisa said, we want our clinicians to practice to the top of their license rather than, shooing people away and everybody goes to their health system. Having said that, if you're part of a health system, you may not have that option, that you're worried about the reimbursement for that one patient. And you do have to send them to get them worked up. So the reimbursement is important, but it's not the only decision making when it comes to selecting a test or how you operate.
Thank you, Payman. So question 8, we alluded to this earlier, but how do we guard against overutilization or inappropriate utilization? Lisa, do you want to start us off?
Yeah, this was a passion of mine. So, the success of any testing program, it has to depend on utilization and also test performance. But strategies that we used to prevent overutilization at Premier was one thing. So we established clear clinical criteria. So we did not want the MA or the nurse giving everybody that came through the door sneezing the triad, the COVID, flu, and strep. We wanted to make sure that their testing was driven by their symptoms, their risk factors, and the clinical decision making rather than convenience. Such as STI testing examples, make sure that do they have symptoms? Have they been exposed? Do they have high risk sexual behavior? Another thing that we did was we built evidence-based algorithms, testing algorithms. This is the symptom. Are they asymptomatic, symptomatic? And follow those as far as, respiratory illnesses. And we looked at a tiered testing approach. And so all of those things combined helped us to negate overutilization of testing because, again, it all comes back to the almighty dollar. You have to think about your reimbursement and all of those testing. Are they necessary? Are they going to change the clinical plan? And we monitored that by looking at the utilization data, looking at the reimbursement data, tracking, each provider, each result, and look through the peer review and look through the charts. Did this adult patient meet Centaur criteria? Did this patient, have body aches and fever? So you have to look at that and then provide provider education and make sure that they understand. Your providers know that problems, sometimes it'll stem from lack of understanding. Make sure they know what is the criteria for testing. Make sure also they know the financial impact. If you're doing a triad on everybody that comes through sneezing and they've got allergic rhinitis, then that's 3 tests that just walked out the door that was not needed. So I think that peer review and feedback is absolutely important to make sure that your clinicians and your boots on the ground frontline people and your staff are understanding those things and ultimately implementing them.
Jessica?
Yeah, I would just echo what Lisa said. I think I like to use an audit and feedback tool. I think looking at things about every 2 weeks, you can kind of see what your utilization looks like on a particular test and whether or not they met criteria for testing or not. So yeah, I agree with Lisa.
Perfect. Kind of question 9 is somewhat related. Do you guys feel that patients are driving requests for testing? And is there any value in tests that may not change clinical management? I'll throw an example out there, RSV testing. RSV testing doesn't really change clinical management, but is there value to a parent or to a patient in having that test result? Payman?
It really comes to what patient maybe watched on TV or they asked ChatGPT, and that would drive what they're asking for, the type of test they're requesting. It really comes to building that report, educating the patient, the circumstances that makes a huge difference. If you build that rapport with the patient in the first few minutes, they will trust you, and then they will believe in your recommendation. Yes, there will be people that they will say, nope, this is what I want. And then that's one of those conflict resolution issues that you have to deal with. But these days, with the readily available information, people ask you for tests that sometimes you have to say, hold on, step out of the room, and you search, see what they're even asking for, because you've never tested or you've never done it, or it doesn't even pertain to our local or the condition that the patient is presenting. So it's really a relationship building with the patient, and hopefully you can convince them with your evidence-based knowledge and availability. Hey, go home and try this. If it doesn't work, I'll come back. I'll work Tuesday, and we can add more tests or whatever we need to do.
Have we seen resistance from patients declining testing?
Well, there's certain tests they don't like to be tested, but since they feel like the treatment is not going to change, or they're not going to accept your treatment, so yes, they don't want to do certain type of tests.
Gotcha. So this is going to be for all three of you. How do you monitor clinician knowledge gaps and distribute educational programs? Jessica?
Yeah, so I alluded to it earlier, audit and feedback. I think that is the best way to identify where your largest opportunities are. So, like I said, I love an audit and feedback. We typically identify a quality initiative every quarter, figure out what sort of reporting that we need to set up in order to do that audit, and then provide feedback to the teams accordingly.
Lisa?
Yes, so Chris, this is an area I spent a significant amount of time on developing at both the organizational and provider level. So to Jessica's point, yes, you do need to look at the different data and observations, but knowledge gaps are rarely identified by asking clinicians what they don't know. They're identified through peer review programs, looking at that documentation, looking at their M coding accuracy and their medical decision making, and making sure that they're adhering to your guidance and your guidance adherence, and making sure that they're understanding the documentation or the medical decision making that's there, that if it's not, if they're not utilizing the evidence-based practice algorithms and the education that you've been given, where is that, where is the deficit there, and how can we come alongside our clinicians and teach them, and make sure that they're understanding. So those one-on-ones are paramount in the success of your clinicians. And, we always want to look at KPIs and organizational data, to Jessica's point, but looking at individual clinician performance can be a big bang for your buck as well. And it's also a clinician satisfier when they see that, hey, this organization is investing in me by sending someone or doing peer reviews and having a one-on-one education session with me, then they think, they're investing in me as a clinician and my long haul and my tenure with this company. So I think it also adds tremendous satisfaction to our clinicians.
Yeah. All of you really alluded to something real important. That is appropriate testing. I joke around. Someone said that the triad, I call it the triple crown, and I call it spray and pray. And I think that not only when we implement testing, we absolutely need to educate our clinicians on appropriate testing so that we don't get spray and pray. Payman, what else do you have what other thoughts do you have?
I think Lisa and Jessica said it perfectly. One thing that we really encourage people, I mean, we had from day one up-to-date available in all of our centers, so they could use the information that they need before they even call me. They can do their own research and come up with the proper treatment. But these days, with not that I'm plugging anything, but like open evidence, and seems like the clinicians, they just love it. They just love it. It gets to the point. They can ask follow-up questions. And then, so it is very, very important that you provide that environment for them so they can do a quick search. And if they're still on the fence, that's what I tell them. If you're on the fence, give me a call, then we can talk through it. And then that would allow me to know their deficits. What are they weak on? Is it pediatrics? Is it with women's health? Is it with mental health, whatever it is. Then at that point, it's my job to provide that education that I feel like they need to take them to the next level and make them a better, more confident clinician. And everybody benefits at that point.
Yeah, excellent, excellent points. Excellent points, guys. Well, we want to close by kind of getting everyone's perspective on what are the positive impacts of point of care testing. I mean, I can't imagine any urgent care not having an extensive point of care test platform. Really, what do you see as the impact of having CLIA-waived point of care testing, or in your situation, payment CLIA-moderate testing options? How does that differentiate you from your competitor or other parts of the healthcare ecosystem?
One of our centers is in a small town, like 4,000 people. And farmers or the local, they never go to the doctor unless they're really, really sick. And when they come in, and if you're able to do the CMP and see their kidney function, or you see a CBC, or they're having active heart attack, a lot of those you catch that otherwise they wouldn't be caught, and people, they just don't want to go to the doctor. But once they're there, you can do the test that you performed. There are people, they feel like, oh, I go to any doctor and they can do any test and give me the results right there and then. But that's not really the situation or where we live. So for the right setting, moderate complexity has tremendously improved our quality of the care that we provide, the unnecessary referral to the busy emergency rooms. We can directly send them to the specialist if they need to. And it really sets you apart, because everyone, the first thing that you think about is, how much is the equipment? How much do I get reimbursed? How much does it cost for the testing? And how much training I need to put in this? And it complicates things. But at the end, if you have a right program and your staff is trained, and it broadens the type of conditions that you can treat on the moment's notice. So I'm all for point of care testing, moderate testing. I'm a big advocate. I know there's a lot of people, they feel otherwise, but it has suited us well, and the community has really reaped the benefit from it. So I'm all for it.
Thank you, Payman. Jessica, how has point of care testing impacted AFC's offerings and the clinical services that you provide?
Yeah, so I would highlight three different things. First of all, we live in a society of having everything that we want to know at our fingertips. I mean, we really do. And in this day and age, if somebody has a question, they literally pull out Google on their phone and look it up, and we have an answer right there. And there is this expectation in society that medical care is maybe the same way. And so having that point of care test where they walk out with a result, I think there's value to that. The other thing I would say, and we talked about it a little bit earlier, is that follow-up. So you have follow-up workload. Now you've got a queue that your clinician has to go through to look at all the results. You've got clinicians following up on other clinicians. Patients, sometimes that can be a little bit more challenging than you saw the patient, you know the result, and you know the applicability of that. So that is also another, benefit of point of care testing. And then the last thing that I'll mention is when you are sending out a huge portion of your labs, there is, and you're set up to where a reference lab is then billing that patient or billing the insurance, there is the possibility that that patient receives a large surprise bill, if you will, from a reference lab. And so that's not very palatable, for your patients. They've just come in, they've seen you, they've paid for their visit. And even though you tell them like, hey, you may get a bill from the reference lab, sometimes it's not what they were expecting. And so that could really result in some dismay on the patient's behalf as well.
Thank you, Jessica. Lisa, any other thoughts on the positive impact of point of care testing?
Yeah, I mean, I think looking at from a clinician's point of view, it helps the clinicians with a more informed treatment decisions during that encounter. It gives them a little bit more confidence in their plan of care. And also from a patient satisfaction point, I mean, patients want to know what they have, and being able to tell that mom, well, she's got COVID or she's got the flu or she can't go back to daycare because she's got this or that. So that's something that I think is also a big thing. Not only the patient satisfaction, but also being able to give them the point of care results and helping the clinician to make the best plan of care for that patient. And again, knowing that this patient has got the flu or has COVID, then you don't have to think about, well, our clinician knows they're not going to get an antibiotic. So you have to pull in that antibiotic stewardship in there. So I think there's very, very many positive attributes to point of care testing and utilization.
Great, great. Well, this concludes our panelist discussion. I'd like to thank Jessica, Payman, and Lisa for spending some time discussing point of care testing, their thoughts and their insights. The final thoughts that I have for our listeners is that it's very easy to say, clinically, we want to test. The financial the financial department of your hospital or a clinic will always say, yeah, but what about the costs? And then there's also the workflow. It's not as simple as just basically saying, oh, let's implement a test. Do use a matrix, do consider all the components, financial, clinical utilization, and workflow and quality, and make sure that you balance what tests you need for your center. This concludes our webinar. Thank you for your participation and attendance.